Hi guys, welcome to Let's Talk About CRPS, the new podcast of MTI CRPS division. I'm Emily, your host for today, and I have with me Sandra, our favorite patient manager and patient care coordinator. Just quickly explain what your position is, what you do with patients.
As Emily was saying, I'm a patient care coordinator, so what I usually do is I communicate with patients, so I'm usually the one, giving them all the information they might need. I usually do it either, via email or through our free consultation, which is usually done, it's a video call, lasts around, half an hour. What we do is we just talk about your case, discuss the treatment, answer any questions that you might have, and of course, just explain in general what the procedure is to access the treatment, basically.
Yeah, exactly. So we wanted to start this podcast because we have so many patients coming to us with so many different questions, so many uncertainties, and we wanted to start this podcast to both get a way to, spread the word about the treatment, about what we do, and most importantly about CRPS. So we've asked you on social media about last week, 2 weeks ago.
Yes, we asked, what questions you would like us to answer, what the topics you would like them to be, for the first one.
Exactly, and the first topic that was chosen on the social media was CRPS treatments. What are the difference and what are the main treatments against CRPS? Yeah. So we've selected a few treatments that we wanted to kind of just
the
talk
main
about,
ones,
just the
basically.
main ones that we hear
all the time
during
from
all the
calls,
patients.
yes.
Yeah, exactly. So we want to talk about nerve blocks. We want to talk about spinal cord stimulators. We want to talk about ketamine infusions, and of course we want to talk about Neridronate treatment, which is the one that is used in Italy. So we're gonna just quickly go through, what they do and just let's dive in.
Yes.
So I want to start with the nerve blocks. So the nerve blocks, basically, they're injecting two kind of medication next to your spine. The first one is a numbing one, and then the second is an anti-inflammatory medication.
Okay.
So they're injecting this near your spine, and basically it helps with the pain. However, the effects last anything between like few days to few weeks, which means the pain is going to come back, and it's a treatment that you're going to have to repeat. And it's important to note that it is a pain relief medication, treatment, which means it will be working on the pain of your CRPS, but it's not going to be working on the other symptoms, which we all know too well. So the swelling, the burning sensation, the muscle atrophy, the change of color, the change of temperature. There's just so many different symptoms that are not as handicapping as the pain, which we know is really, really handicapping, but which are equally, disabling. So it's important to treat these treatments too. And the nerve blocks don't do that. It's just a pain numbing treatment. So it's gonna help with the pain, and it might be a good option if you want to wait for another treatment. Yeah, exactly. And you just want to have something that is kind of numbing the pain. However, super important to note, I found out when I was looking, doing some research on the treatment, 56% of patients do not experience results, which I think is really high. So it's definitely, if you have the option, maybe while you want to wait on another treatment, you can. Be aware that only 43% of people do get results. So it's, I feel like it's a very
they actually
high.
have to repeat it, not weekly, but almost basically.
Yeah, because I read that, the effects can last from few days. Few days is really low. So you have to go and get an injection near your spine, and it's going to be lasting just maybe only a few days if you're lucky, few weeks or few months, but it will have to be repeated. So a good treatment, I would say, in waiting to get something else, or in helping with the pain if the pain is really, really high, but still not a treatment that is going to bring you relief on the long term, just something that's going to help short term. So that's my take on the nerve blocks. you wanted to tell us about the spinal cord
stimulator. Which is a big one, actually. A lot of people, you know, they just call it usually their last hope when it comes to CRPS. Like a lot of people who come here, you know, either have it in or they had it in, they had to take it out, you know, and it's something that I wanted to touch a little bit since it's so common in the past years, at least, what I have seen, you know, with patients. So yeah, you might have seen or might have heard that a spinal cord stimulator is an implanted device, actually, that is supposed to send these low levels of electricity directly in your spinal cord, which is supposed to, you know, relieve the pain through these electric signals. I've also read, and of course, it has to be implanted. What they usually do is they have like a trial, and it's a trial that actually is done outside of your body, so you actually have the device out, but it's still, you know, placed near your back. And based on the trials, if you do feel any pain relief, they usually, you know, proceed with implanting it. But it's done. Which is a surgery then? It is a surgery, yeah. It's actually done surgically. So they have to, you know, attach it to either, you know, your lumbar spine or up in the thorax, I guess, or the cervicals, based on where the pain is in this case in your back. And I was reading a bit about what the risks can be, what patients can expect from this, you know, and the majority of the risks that I have seen is basically, you know, an infection, because it's surgical, so you can never know if your body is going to like reject it or what, because not everyone is going to, you know, have the same reaction to it. Another major one that I have seen is that it can actually move somehow in your body sometimes when it's not placed properly, I guess. Leads can move out of positions, you have like screws going around. And this is something very interesting, because I did have a patient about 2 years ago, maybe, almost 3, like right after COVID, I think. Who did have this issue, like he was basically just floating around in her back, which is insane to me, like, my God. And yeah, what do you do in these cases? You still have to, you know, remove it, I guess, or like reopen the same scar and just fix it again. I'm not quite sure. But yeah, there's lots of issues with, you know, scar tissue, which is also a major problem for CRPS patients, who just, you know, already have the pain going on. Put on top of it like the scars and everything else. I don't know. Another interesting thing that I read about it is that it's actually not indicated for pain that is stemming from bone pain, like, you know, anything going on with your bones, basically. Tissue pain and arthritis, like people who are dealing with arthritis, but also people who are dealing with fibromyalgia, which sometimes has very similar.
It has a lot of similarity with CRPS, so that's weird. So it's not really advised for this kind of chronic pain.
Yes, exactly. So
coming from the tissue.
Yeah, it's curious to me, you know, how much it has been advised to patients, like as a proper treatment.
And it's super invasive, so you have to be sure that it's going to help.
Yeah, with this kind of they're just going to open up your back. I've also, you know, they usually expect about a 50% of, you know, pain decrease, that it's not sure that it's going to be lasting, because sometimes, you know, any malfunctions can actually lead to the pain just being stable, I guess, and not, you know, lowering any longer after. But yeah, I've had a lot of patients, you know, just coming here and, you know, having it. And
does it work only on the pain?
Usually, yes. That's what I have heard. Like, it's supposed to work on the pain. What the electrical signals are supposed to do is basically just, you know, lower it and just numb it for a bit. But yeah, I've heard a lot of, you know, horror stories about that one, so I just wanted to, you know, share it. Of course, it can definitely work for some people, but I would not call it something that it's lasting. Like, you just have to have it there, and what happens once the signal isn't strong enough anymore? Or when the pain gets, you know, worse, what's next? You know,
or if the screws get around in your body.
Exactly. Yeah, that's
I'm so shocked. I'd never heard that before. That's insane. And it's just so invasive. You know, I think it's just not something that I would advise to anyone.
With, you know, they even say that surgeries are not advised for CRPS patients, mainly because they can lead to new traumas in that same area, and they're just not advised. You know, even before coming here, we always tell patients, you know what, you should get, you know, any surgery that you need to get, like mandatory ones, you just do that first and then come to us, of course. But that's just to avoid, you know, any additional trauma to your body, since every surgery is just, putting your body through that. Yes,
it is a trauma, 100%.
So yeah, that was my take on this so far.
All right. So my next one are the ketamine infusions, which I think is the most spread options in the States that I hear a lot from our patients. Ketamine infusions, basically it works by blocking the specific neurotransmitter that allow you to feel the pain. So once again, we are talking about a treatment that is only focusing on masking the pain and not really working on dealing with CRPS itself. I think that's something that's very common in all of the treatments that we've talked about and the ones that we've heard throughout the years. It's just really focused on helping with the pain, but not really dealing with the disease. So the ketamine infusions have to be repeated every month and a half, depending on every patient.
Okay.
And the more you repeat it, the more the dosage would have to get higher.
Because your body gets used to it?
Yeah.
Okay.
So you would have to get on higher and higher and higher zones. Dose, sorry. and that means a lot more risks of, side effects. And I was on the Mayo Clinic site, actually. I was looking at the side effects that they talk about. And I want to have a zoom on that because this is the list.
Oh my God.
And I feel like I don't know, it's just, some of them are literally bloody urine and blurred vision, confusion. I've had a patient that said that while she was taking it, her husband was there and she was like, "Who are you?"
Oh my God.
I feel like there's just a lot of dizziness and lightheaded and I'm reading all of this. Not breathing is one of the what?
Okay.
Sweating, trouble breathing, restlessness, hearing loss, seeing or feeling things that are not there. We are talking about a drug in the end. So I've had so many patients taking that treatment.
I was about to comment on that. A lot of people tell you that they're out of it for days after, and that's 100%. The thing that numbs them because they're not there.
Yeah.
Mentally speaking.
I mean, I've heard that it does help with the pain, but once again, it's just the risks are pretty high, and we're talking about something that is not permanent, that you're going to have to keep on doing all over again. And like I said before, you're going to have to get on higher dosage the more you go. So once again, I would say this is something that you might want to do. I have some patients that are coming maybe in September because they couldn't come before. And before September, to be able to take on the pain, waiting for the treatment, they are going through ketamine infusions just to help with the pain.
That's what we hear the most,
So that's something that I would say, again, like the nerve blocks, just something to help in the meantime, but definitely not a definite treatment or something that's going to help you and then you're fixed. So those are still kind of, just not permanent. What's the word for not permanent? Temporary. Temporary, yeah, there's just temporary treatments. So, which is what takes us to, the last one that we want to talk about today, which is the Neridronate treatment. Of course, we're going to be talking about this one because that's the one that
has actually, been patented for this.
Patented for CRPS, and that's the one that is used in Italy, and that's the one that we work with so often with our patients, and the one that we've seen the most results for. So I'll let you tell us a bit more about Neridronate, the side effects that they have.
They're not a page long, I swear.
There's not a Google page long of it. And just go ahead and walk us through, Neridronate.
Well, as you know, as you might have read from our website, I sure hope you did, Neridronate is a bisphosphonate. Yes. It's from the family of bisphosphonates, and it's the one that actually has been studied, scientifically speaking, we have studies on it, and that has been approved for the treatment, of CRPS in this case. We don't call it cure. We're not gonna get, to that point because it wouldn't be true. But it's a treatment, yes, and it actually has been proven to show results in patients. What it does, it actually acts on what the root of the issue is. So we're not talking about numbing the pain. We're not talking about, just working for a couple of days and then you have to repeat it. No, it's something that we do once. So those 4 infusions are more than fine. You don't have to come back for more. But yeah, it's supposed to act on the root tissue, so we're talking about where the first injury happened or wherever actually the CRPS spread in your body, because you know, sometimes it actually moves from one limb to the other. But yeah, it's supposed to act, you know, in the bones, in the nerves, in the tissues where the inflammation is going on. So that's where you will be feeling it working a bit in your body.
And the fact that it works on the initial area, the affected area, means it's going to be working, like you said, on the root cause of the CRPS, which means it's going to be helping the CRPS, not the pain, but the CRPS.
Yes, by doing that, of course, the symptoms that stem from it, like the discoloration, the swelling, the pain,
automatically,
it's supposed to, you know, like slowly just decrease and disappear, you know, that would be the best outcome from this. As you might have read, it's 4 infusions, so it's not more than that. You stay here for about 1 week, 1 week and a half, depending on how long you'd like to rest a bit more. Yeah, we always start on a Monday, so that's usually our treatment plan, and by Friday of the same week we are done. So it's 1 infusion per day, and they last, you know, 5 hours, 5 hours and a half, depending of course on what we couple them with, because you know, during the evaluation with our doctors, he can actually advise, you know, some supplementary medications, I would say, that can just boost the effect of the Neridronate. And it will depend on the case, you know, everyone is different. So, you know, we treat children, we treat older people. So based, of course, on the severity of the case, we're just gonna, you know, have the doctor tell us what's best to do. Yes.
We have seen such a wide variety of patients, I think, throughout the years. I think we've both been with the company for 7 or 8 years now. So my youngest patient was 11, and my oldest patient, I think, was like 78.
Something like that,
And then I've seen, you know, anything, women, men, patient who just had it for 2 months, 3 months, people who had it for 26 years.
Yeah, that was one of mine. It was great, actually.
So yeah, we have seen everything, and we have seen it helping so many different cases. So of course, the original study was done on people that had it for 4 months or less, which all led to remission. So 100% of the patients who went through the first initial study that was then leading to the patent of Neridronate all went into remission. And 6 months after, the result was still showing that they were 100% in remission.
Yeah, we also have like something, we've had an article from 2023, I think.
Yeah, the newest
one, that was showing that even after those, you know, first year from the remission, I think.
It was 3 years. 3 years after, the symptoms were still not. So it was just a study to show the permanentness of the Neridronate, of the treatment.
The symptoms weren't coming back after 3 years, I believe.
And so the original study was done on these patients that had it for a very short amount of time. But we've also seen so many different cases. I mean, I remember this patient that had it for 12 years and went into remission. It's kind of
singular.
It really depends. It's so singular. It just really depends of the age, the sex of the person, how long they had it for, what is their lifestyle, what is their alimentation style, what has it spread, what kind of CRP. It's just, there's so many factors that you can never really, there's so many patients that always ask us.
That's why it's so hard to tell them.
What is the percentage? And it's so hard to reply to that. I wish I could. Because I wish I could tell you like, oh, this is what you're gonna have, but it's just so personal. It's just a question that's impossible to reply
we have been tracking, you know, you might find also that on our website, you know, the different case studies basically. So you can actually find the person who resembles your case, you know. You're able to read what the outcome for them was. Of course, we can't tell you that it's going to be the same for you, you know, but at least you know that there's people out there who have the same...
This kind of result.
Yeah, exactly. So yeah, we've seen a lot of stuff, I think.
And you know, in the original study, literally in the conclusion, you can read the scientists saying, as for now, this is the best treatment choice for CRPS patients. And I think even now in 2024, it is 100% the case. From all of the patients that we welcomed here in Italy, we've seen them try so many different treatments before.
Yes, definitely.
And finally arriving to us after so much, you know, research online.
Trials and tribulations.
Exactly. We should do a series. We should do like a web series. This CRPS trials and masturbation.
I should keep a diary with all,
oh my god, yes, we should. So yeah, we've seen it ourselves, you know, we've seen the best results from this treatment, which is also the reason why, you know, we do what we do, because it's not just wanting to get someone to come here for treatment. We don't get anything out of it.
Yeah, we're not,
it's
you know,
just
begging people to come. We're just giving
we're not getting paid by the government to do that, just FYI. It's just basically giving access to international patients to the Italian healthcare, because this is something that we currently have in the healthcare that is standard treatment.
Since we have this country, and this country is the one who was able to, you know, have this as a treatment, discover this treatment, why not try to, you know, just spread the word and
share the information,
let people know that, you know, there's something out there that can actually help them. That's the goal.
Yeah.
You know.
So yeah, basically, you know, we've talked about just about 3 or 4, was it, treatment?
Yeah, I mean, there's many more.
But there's many more. Yeah, there's, you know, mirror therapy, there's
the
acupuncture,
therapy.
the aqua therapy, I've heard. There's just so many different things. The calmer therapy. There's just so many things I heard throughout the years.
Chiropractors and, you know.
So many different, you know, treatments over the years. And from what I can see, and from I think what we all can see, currently 100% I would say if you have the chance to do it, Neridronate is the best chance that you would have. We did ask on our socials if anyone wanted us to touch some specific topics in this podcast, so I want to just read the questions that we had. The first one was, why isn't Neridronate an option in the States? That's another question that we have like
oh my
daily.
god, yeah, that's you know, something that we get asked
Someone
almost
asked
in every
me, like, why
video
do
call.
you not make it available in the States? And I was like, first of all,
it's not our fault.
It's not me. I'm not in charge of Neridronate. No,
we're not in charge of the FDA.
I'm not. Yeah, I know. We know there was some trials in the States back in a few years ago.
Yeah, I think it was like a bit before COVID, I think.
It was before COVID.
Yeah, definitely.
But there was some things that, you know, weren't really following. They didn't follow the Italian protocol.
They didn't. They also didn't have the right people for it. Like, the patients didn't have the diagnosis like of CRPS. They just had chronic pain in general, I believe.
Yeah, but one of our patients throughout the years was a neurologist, and he actually told me that. He was like, oh, I was reading about, you know, the trial in the States, and I read that some of the people didn't have a confirmed diagnosis for CRPS, which of course is going to mess up with the results.
Yeah, you're not going to get the same results if you don't have it.
Because you're not treating patients.
Yeah, exactly.
Yeah. And then of course they use another pharmaceutical company, so it's not, they're not using the same company that is used here, and they're not using the same protocol. So the trial
the dosage is not the same, so of course you're not supposed to.
So of course the trial didn't go well, and then they just stopped it, which sucks for any, you know, CRPS patients in the States, because they felt like there was hope for a while.
Yeah, and there's so many of them. That's the thing. Like,
I
would believe that by now they would have, you know, come up with something, you know, or even try to, you know.
But try in the right way. If you're gonna try, do it in the right way.
Do it the right way, you know.
I had a question. Let's make you take that one.
Okay.
What's the difference between Neridronate and other bisphosphonate?
The main thing is that the other bisphosphonates are not meant for CRPS. That's the thing, yeah.
That's one.
We hear a lot about, you know, pamidronate, alendronate, everything from that family, you know, and they're always like, yeah, but, you know, my doctor uses this for osteoporosis, you know, can I use it for CRPS? You can use it, but it's not going to give you the result that you want, because it's not meant for this kind of condition, you know. And the thing is that when you actually have a bisphosphonate, you know, as a treatment, and then you want to come here, usually you would also have to wait a bit longer. That's something that we have checked in with our doctors, you know. It would be good to just, you know, wait a bit if you have tried anything else. But yeah, the main difference is that they weren't patented for this, and we can't tell you that they're going to help you, because we don't know. They weren't studied for CRPS, you know. So
what the doctor also said is that from all the family of bisphosphonate, Neridronate has the widest range of action, which means it can actually touch much more ground.
Okay.
And just, you know, wider range of action. I don't know how else to say it. But just like the other ones are much more precise and focused on one specific thing, and Neridronate is just the widest one of all the Neridronate of all the bisphosphonate, which is also why, you know, it was shown that it has the best results for CRPS when the others don't. So someone asked, for someone who cannot come to Italy, what is the second best option? So that's hard, just because what we've said before.
Yes.
They're all very focused on masking the pain. Rehabilitation, 100%.
Definitely.
Physical therapy
Physiotherapy is
from day
important.
one.
Yes, definitely.
We haven't
even
talked
when coming
about it.
here, yes, even when coming here, you have to keep doing physical therapy.
Yeah.
Like at least for the 6 months after the treatment.
Yeah.
Like that's when you actually have to hit hard on the rehabilitation. But even after, a lot of people,
day one, I think.
yes, a lot
From
of
day
people,
one.
lose muscle, they lose mobility. So
Yeah.
it's an important part of recovery, I think.
Just
And
keep on moving 100% from the beginning.
definitely.
Work on your diet, work on eating things that are not inflammatory.
Like inflammatory, yeah.
Yeah, and yeah, I mean, there's just so much things you can do without the actual pharmaceutical treatment, I would say. So just, yeah, keep on moving. Physiotherapy,
Yes, definitely.
Food, just healthier food, healthier alimentation. Acupuncture has been helping, but it's just so much you can do without the pharmaceutical treatment.
Yes.
But there's just, things you can do in your lifestyle, I think, that will help.
Yeah, just
up to a
improve,
certain point,
just
at least to
improve,
just improve your daily life.
Yes, exactly.
Yeah. What treatment would you not recommend?
The ones that we just said.
No, it's not that I wouldn't recommend
I mean,
it.
yeah.
It's just that, like, so there's some that I have in my mind that I wouldn't recommend because it's shown that it's not really helping in the way that it should. I don't think I can say it. I think we'll just answer more widely on that. Just I think
anything that can bring you harm, I would say.
Yeah.
Like anything that's dangerous for your
the
health.
risks are higher than
Yes,
the possible
exactly.
benefits.
Exactly.
I would say
to just check the side effects first of
Yeah.
anything you try.
100%.
Be it medications, be it anything.
Yeah.
And
if you want to go and undertake something, just take a look at the reviews always
Definitely,
of
yes.
any clinic, place, or whatever. Just take a look at what everyone says because I think it's important. 100%. And then just talk to your primary doctor and really see, for the side effects, for the possible complication of anything, in particular for your special case. I think just talk to your doctor and understand, you have to understand the risks and just understand if the risk is worth taking. Yeah. That's we will stop there.
Yes, we won't get into that too much.
What's the difference between Neridronate and ketamine? I think we've already kind of touched on, but the permanency of Neridronate and the not permanency.
How lasting, the results can be, and of course the side effects, I would say in this
100%
case.
the side effects.
Yes, you have
so
to
the
wait
side
on
effect.
that,
I don't think you've talked about it. The side effects of Neridronate. I don't think you said anything.
Okay. I think I missed that one. Well, the only thing that we have seen, from patients and heard, we call them flu-like symptoms. That's what it feels like. You just have a bit of bone achiness for a couple of days, which is quite normal. As I was saying, Neridronate acts in the bones as well. So that's where you will be feeling it too. But, we give you some Tylenol after the infusions. That seems to help a lot.
Yeah.
Patients are more than fine after a couple of days. And whenever they are ready to go back home, they should be feeling fine.
Yeah, 100%.
Yeah, that's really what we have seen,
And it's not showing in all the patients.
No. A lot of times it happens with younger people we've seen, or people who are not used to, taking any medications.
Yeah.
While people who, take a bit more on the, pain meds, I would say, they usually feel just fine. Because it's not, hard as a medication.
Aggressive drug.
No, at all. No, it's not aggressive.
Not invasive at all. Yeah, definitely. And then, just the fact that you have to keep on going for ketamine. And
I would say,
Neridronate is
you
just
do this
permanent.
once, and that's it.
And the type of drug, I mean, we're talking about bisphosphonate, which are so non-invasive, and then ketamine, which is
that's
pretty strong. So there's just a lot of difference.
ketamine is not even used here, I think.
It's a horse tranquilizer.
It's a horse
So
tranquilizer.
it's used, but not for the same kind of thing. Yeah, it's just that it would be comparing literally like, I don't know, the States and Asia. It's just two completely different things.
No, there's no way, you know.
What's the best treatment option? I think we've covered that. I think, you know, if you look at the side effects, if you look at how many times you have to do it, if you look at is it invasive or is it not, the trials that were done on it, is it patent for CRPS, you have your answer.
Yeah, exactly.
Neridronate.
You just have to read a bit more, you know.
Yeah. What are the risks of Neridronate treatment?
As I was saying, there are no lasting, like there's no risk. It's not a risk. It's just a side effect that you can expect.
And even the side effects, I wouldn't call them a risk.
No, it's just something that happens sometimes based on, you know, the singular patient.
Yeah,
but
there's no
risk
long-term
in itself.
risk.
There's nothing lasting. No, there's, you know.
I know that so many patients ask me this, so I'm gonna be putting myself
asking
in the patient,
okay.
and then I'm gonna ask you, what about jaw necrosis?
Oh my God.
And there's just so many people writing about it online, and there's just so much miscommunication on it, which is why I think so many patients ask us. So give us the truth.
The truth is that jaw necrosis doesn't really happen when a bisphosphonate is done, you know, via IV infusions. We're talking about bisphosphonates they are taking, you know, orally, like with, you know, any pills. But in that case, if you're looking for jaw necrosis, you would have to be taking very high doses of it for a very, you know, long period of time.
And
it's
very
something
often.
And very
We're
often,
talking about like taking it every day, orally for like a month, 2 months, 3 months.
And
so
it's always orally speaking. So you know, in this case,
it's
the infusions are going to work in the limbs, like where the CRPS is. So there's no way for it to, you know, come in contact with your jaw in any way. So this is something that has been answered for a long time, year after year, but you
it's
know,
fair because if I would see this, you know, if I would read this, I would be like, no, hell no, like I want to have an answer. But, you know, so it's a fair question.
It is.
It's just so different, like taken orally versus taken on an IV, taken super frequently for super long period of time versus taken 4 times on 4 days and that's it.
Yes.
So it has been linked to bisphosphonates, but in a whole different kind of way of taking it.
Exactly.
I'd say. Is the Neridronate treatment helpful for everyone?
I would say the same thing we said before.
Yeah.
It's, you know, it's very subjective, I would say. I can tell yes, like I can tell you yes at the moment because
no, I want to say yes because like it's such very rare cases in which it didn't show any kind of
it's difficult
results.
Mainly because it's a medication, so it is going to work. Like there's no way for it to just not show any signs in your body, I would say.
Yeah, the difference is on the amount of results that you have.
Exactly. So maybe, you know, people maybe, you know, they are looking for, I don't know, not even remission, but maybe like a higher percentage of pain remission, and they maybe, you know, it's cut a bit short for them. So in that case, you know, they might be a little down about it, but there's no way for it to just not, you know, act in any way, I think. Like it's
the cases in which it didn't show any kind of results were very rare. Usually were included a lot of different medical history and difficulty, others difficulty.
Yeah, or like any other underlying condition that might be, you know, causing the pain and not letting, you know, the medication do its course, I guess.
Yeah. So other than that, it's just really a matter of what kind of percentage of improvements you will get.
Yes, exactly.
More than like, is it going to help everyone? Is it how is it going to help?
Yes.
Which again, which we said before, it's not really an answer that we can have because it's so different from one patient to another.
Yes.
But 100% from what we've seen so far, it's just such a low percentage of people that haven't gotten any results. And then it just varies, you know. Some cases that had it for 17 years maybe will have like 30% improvement, which is still a life-changing improvement when you've had it for 17 years.
Yeah.
And then some cases, like I said before, the 12 years case just went into remission. Like there's no way that we can know. But yeah, results we will see in like, I think it's 98% of the cases.
Yeah. I would say that too, yeah, definitely.
So yeah, it would help everyone, I would say. Okay, yeah, that's it. So we've touched kind of, you know, the main treatments that we hear of by our patients all the time. We went a bit deeper on Neridronate because that's the one, of course, that we had the most data on. And then we touched the questions that, you know, you guys had for us throughout the week on the socials.
Yeah.
So that's about it for the first episode, I think. That went
thank you
really
so much for
well.
listening, if you're listening.
If you're still listening. Yeah, subscribe to our podcast because
we'll be doing this a lot.
Yeah,
and
we're gonna
just, you know, we're people who like to talk. So if you have, you know, questions or anything you like us
we like to share
to
information.
talk about, we're here. Yes,
100%.
definitely.
We want to share as much information as we can on, you know,
open-mindedness. It's important on this. So, yeah.
So follow us on our channel on Spotify and wait for the next episodes. Follow us on our social medias. On Instagram is where we ask mostly, you know,
the weekly questions.
On what you want the next podcast to be about, and then specific questions you want to ask during the podcast so that I can read it with my next special guest. And yeah, that's about it. You guys, thank you so much for listening.
Thank you so much. Bye-bye.
And we'll see you on the next episode.